Hello, and welcome to the Abnormal Psychology chapter on anxiety disorders. So, as usual, let's define some of our terms that we're using. And in this case, it's the difference between stress and anxiety. Now, stress and anxiety are often used synonymously. Many times when we actually mean anxiety, we use the term stress. If you look at the box on the right, you see the difference between stress and anxiety. Anxiety is emotionally driven. Stress is instinctual. Anxiety builds up over time. Stress is usually immediate. There's a deer in the headlights. That's the anxiety, the freeze. The stress response is usually fight or flight. And if you look at the picture on the left, stress is caused by an existing stress-causing factor, something that's external, called a stressor. Anxiety is stress that continues after the stressor is gone. So maybe this person's allergic to bees, and so a bee is flying around him, and he gets stressed. Then the bee flies off, but he continues to worry about it. That's anxiety. Does that make sense? Then let's look at anxiety and fear. So anxiety is apprehension about something that could happen in the future. Fear is a response to something that's happening right now. It's immediate. They both involve the sympathetic nervous system and have similar somatic physiological arousals. Both can be adaptive. Anxiety increases preparedness. In sports psychology, they often talk about the Yerkes-Dodson inverted U curve, where you have to have a certain amount of stress or anxiety in order to be alert. If you have too much, then there's you don't perform well. So there's this optimal performance. You have to have a certain amount of anxiety before a sports event. Now I want to look at anxiety disorders, when anxiety becomes a disorder. So we're going to look at specific phobias, social anxiety disorder, general anxiety disorder, panic disorder, agoraphobia, and I already said generalized anxiety disorder. So these are the most common psychiatric disorders, and 28% of the people report anxiety symptoms, and the most common of these are the phobias. So you have your DSM5 criteria. Obviously, it has to interfere with your functioning. Symptoms are not caused by a drug or medication. They last for at least 6 months, and they're distinct from other symptoms or another anxiety disorder. And the symptoms for each of these disorders are in the text and in the DSM-5, and I'm not going to go over each one of them. The phobias. So phobias are disruptive or disproportionate fear of a particular object or situation. They're often referred to as irrational fears. So they're way out of proportion with the actual threat, the fear of flying, fear of spiders or bats or snakes. There's a high comorbidity rate of specific phobias. They can cluster. And of course, they must be severe enough to cause distress in your life, interfere with your job or social life before they're referred to as a disorder. And the usual way that people deal with these, the usual interference with life is avoidance. So people that are afraid to fly or won't fly. John Madden, I don't know if you remember John Madden, was an announcer, football announcer, didn't like to fly, had a fear of flying, and so he would go from city to city on a bus. So there's specific types of phobias. Probably one of the most well-known is claustrophobia. That's the fear of enclosed spaces. There's a list over here of the top 10. It appears that the fear of spiders is the number one phobia. For years, it's often been said that public speaking is the number one phobia. You can see down in the bottom left, there's a joke by Jerry Seinfeld with that in mind. According to most studies, people's number one fear is public speaking. Number two is death. Death is number two. Does that sound right? This means the average person, if you go to a funeral, you're better off in the casket than you are doing the eulogy. So what's the difference between a normal fear and a phobia? It's not unusual to feel anxious if you're flying through turbulence or through a storm. But it's a phobia when you're not going to go to your best friend's wedding because you have to fly to an island to get there. You can look down that list, go back and forth. Up in the top right are some of the strange phobias that people have. The coultrophobia, or the fear of clowns, is made a lot of in movies and stuff. Some people are afraid of holes, like in sponges or a honeycomb or something. We laugh at some of these because they sound ridiculous, but if people truly have a fear of them and it interferes with their life, it becomes a problem. So how do they come about? Well, there's this two-factor model of conditioning that starts off with classical conditioning and then moves into operant conditioning. So classical is stimulus response, operant is reward or punishment. So let's say this uses the example of a dog biting someone. You're classically conditioned to fear dogs. Then that motivates you to avoid dogs. The avoidance gets reinforced operantly because it relieves the fear. Make sense? If it doesn't, think about it for a minute. So as we move into looking at some of the specific phobias, there are certain things that all of them have in common. And one is that two-factor model of behavioral conditioning. We're conditioned to the response of the threat, and then that gets reconditioned, if you will, by our safety behavior, which is usually some type of avoidance. The extension of the two-factor model is the fact that you can watch somebody else experience the stimulus or be harmed, and that's enough for you to embody that you're not gonna do it. So let's say if you saw somebody get hit by a baseball pitch and knocked out, that may be enough for you to say, "Oh, I'm never going to play baseball because I'd be afraid that that would happen to me." This can also be exacerbated by a parent scaring a child about certain things, warning them about the danger of something until they create a true fear. And then once that's conditioned or imprinted, it's very, very difficult to get rid of or make it extinct later on. And of course, then there's prepared learning. We know that there's certain things that are dangerous, snakes, heights, so forth. Uh, these are normal fears unless they uh, overwhelm us. So the first uh, anxiety disorder we'll look at is the social anxiety disorder. It used to be called social phobia. Uh, it causes a tremendous amount of disruption in your life. It's more intense and more extensive than just shyness. Being shy does not mean you have a social anxiety disorder, but it has this list of these symptoms: persistent, intense fear and avoidance of social situations, fear of evaluation of scrutiny, which is why there is the fear, uh, and they're just terrified of being embarrassed or humiliated. And so all of these things work together, uh, and so there's an overlap with the avoidant personality disorder. Uh, they kind of go together, comorbidity, if you will. So where does it come from? It's similar to the specific phobias. And then the negative cognitive factors, negative beliefs. Uh, you expect people not to like you. You're very self-punishing, self-judgmental. And so you figure everybody else must be doing the same thing about you. Then the generalized anxiety disorder, it involves just chronic, excessive, generalized, uncontrollable worry. As the last 6 months, certainly interferes with daily life. You can't decide on a solution or a course of action. The dilemma is shown in the cartoon on the right. They're anti-anxiety pills, but I'm afraid to take them. Then you have the irrational thoughts. God, don't let the ceiling fall down on my head tonight. Now that would be a real fear if you lived in a war zone, but in our everyday life, that should not be something that you're losing sleep over. And one of the sad things about this is that it begins early enough in life that later on, when somebody asks you, the person says, "I've always been this way." So there's some GABA system deficits in the brain. The cognitive model is not exactly the one that's on the right, but I like the one that's on the right. Again, thoughts, feelings, and behaviors. The thoughts, I feel bad, so the situation must be bad. I can't cope. Okay? Something terrible is going to happen. So these are the thoughts, whether they're real or whether they're imagined. They make you feel anxious and fearful and even give you physical sensations, heart palpitations. You may be sweating, your pulse rate runs. You try to cope by doing things that make you feel safe. What's the way to do that? Either you freeze or you avoid. You get out of the situation. And then that reinforces and goes around in the circle. It's really a sad situation. So I'm going to throw in just a little positive psychology here for a moment, or positive thinking. One of the things that I teach in positive psych is that worry is negative goal setting. Okay, because you're focusing on the worst outcome as opposed to what you want to happen. So you're focusing on what you don't want to happen. And so the question I ask when I'm working with clients or with my students is, does worrying help? And the answer is no, it doesn't. If you look at the worry chart up in the top right, 40% of the things we worry about never happen. 30% have already happened. We can't do anything about them. 12% are needless. 10% are petty. 8% are real worries. Half of them we can do little about, and the other half we can. So there's about 4% of the things that we can do stuff about. So take care of those and quit worrying. The other thing from a self-talk standpoint is anytime you say I'm worried about something, snap that rubber band and say I'm not worried, I'm concerned. Okay? There's a big difference between worry and concern. So I have a little picture there from the movie Bridge of Spies. Tom Hanks played a lawyer who was defending a guy that was accused of being a Soviet spy, and he could get the death penalty. And Hanks says, you don't seem very concerned about this. You don't seem very worried about it. And the guy just looked at him and said, well, would it help? And the answer is no, it doesn't. So don't worry. And beyond the song, don't worry, be happy. Don't worry, be concerned. That's all. Change your self-talk. Okay, I'll get off my soapbox now. So let's move into panic disorders. Another form of anxiety disorders. They go along with they can go along with the social anxiety and the general anxiety disorders. They usually involve a panic attack. Now, you can have panic attacks without having a panic disorder. But if the panic attacks become regular, then you've got a panic disorder. Now, a panic attack, the reason they call it a panic attack, and I know this firsthand because years ago I was in a very stressful situation and I had a few panic attacks as a result of that. And the first time I did it, I was getting ready to drive home from work and pulled up on the parkway, and it felt like somebody reached inside my chest and started squeezing my heart. And I literally thought I was going to die. I pulled off to the side of the road. I was sweating. I was terrified. I knew I was having a heart attack. I knew that I was going to die. And then you panic. Okay? And the panic leads to more of the symptoms. Eventually, it calmed down. It went away. Seemed like it took an hour. It was probably less than 10 minutes. When I told my doctor about it the next day, he told me what it was. Well, it sounds like you had a panic attack. And, we talked about the stress and so forth. And he said, well, the next time it happens, just focus on your breath. You know it's not going to kill you now. So I only had 2 more episodes of them, and each one was less severe than the first one. And I was able to just pay attention to my breathing, focus on my breathing, and they went away. Now, this doesn't happen for some people. They keep coming back. And it can be, again, there's a lot of comorbidity with panic disorder. It goes along with some of the other things, some of the other anxiety disorders that we're going to talk about. So what happens is it's usually uncued. In other words, you may be under a lot of stress, but in my case, the stressful part was over of the day. I had to deal with a situation that was ongoing and becoming more and more stressful. Now I was I was going home, I was starting to relax, and that's when it hit me. Okay. Now, sometimes you can have a cued panic attack. For example, the example they give here is, you see a snake and then you have a panic attack because you have this terror of snakes. But what happens what makes it turn into the disorder is that you're worried you're going to have it again. That worry, just like the panic cycle on the right-hand side, is you have anxiety, it leads to a panic attack. There's a fear of another one. There's more anxiety, leads to another attack, leads to more fear, leads to anxiety, leads to another panic attack. So it can be a vicious cycle. So where do they come from? What's the etiology of the panic disorder? Well, there are some genetic factors that may increase the risk of the panic disorder. Okay, it could be some brain functioning or just your response to the stress initiation. There's behavioral factors, the conditioning, okay, cognitive factors, catastrophic misinterpretations of your somatic changes. I think I'm going to die. That's enough to make you panic. And then if you have what they refer to as a high score on the anxiety sensitivity index, unusual body sensations scare you. As soon as your heart starts beating rapidly, you worry you might have a heart attack and so forth. So if you look on the right, there's two feedback loops, the behavioral and the cognitive. I'll give you a moment just to look at those. Okay, so the next anxiety disorder we want to look at is agoraphobia. People that have agoraphobia are the ones that you hear about that won't leave their house. So they're afraid of crowds, stores, malls. This can cause significant impairment. It used to be a subtype of the panic disorder, but at least half the agoraphobics don't suffer panic attacks, so they reclassified it. The etiology basically comes down to a fear of fear. You're afraid that you're going to be afraid. So it's going to be like the panic attack from the standpoint you're afraid you're going to have another one. Same situation here. You're afraid that you're going to be afraid, and that ties in with you're afraid because you think people are judging you. What will people think of you if you have a panic attack? If you show fear. So it's this horrible mental game that people play, and again, for those of us not suffering, you just say, well, that's ridiculous. Snap out of it. But because they get into these cycles, they can't just snap out of it. They need help. Women are 2 times as likely as men to have anxiety disorders. There's some explanations there. Women are more likely to experience childhood sexual abuse. That can lead to it. There's cultural factors. If you're a practicing psychologist, you may need to know what some of the culturally specific syndromes are, and the rate varies by culture. So 50% of people with anxiety disorders meet the criteria for a second anxiety disorder. Okay? 75% with an anxiety disorder meet the criteria for another psychological disorder, not just another anxiety disorder. So it can be tied in with depression, with substance abuse, personality disorders, medical disorders, and so forth. You get just a little bit of the idea of how they can tie in with each other, looking at the image on the right-hand side. So what increases the risk of having more than one? We're back to conditioning. We know that. There's some genetic vulnerability. We don't know how much, but it's not more than 50-50 in most cases, and it's probably less. But it gets tied in with that conditioning. There's behavioral inhibition. Okay, that's where you have a disruptive behavior that again gets conditioned. There's neuroticism, constant worry about things, and then negative thinking as opposed to positive thinking. Sustained negative beliefs, perceived lack of control, and increased attentions to threat cues or hypervigilance. When we look at the risk factors for anxiety disorders, there's a definite genetic heritability link. So right now they think 20 to 40% for phobias, generalized anxiety disorder, PTSD, there's about a 20 to 40% heritability rate. It's about 50% for panic disorders. What we do know also is a relative with a phobia increases the risk for other anxiety disorders in addition to that phobia. And that relative with the disorder, if you think from the nature-nurture standpoint, the heritability being the nature, also if that relative is a close relative and is around you or the person that's growing up, for example, a child, if they have if say your mother has a panic disorder or a social anxiety disorder, not only could it be passed along to you hereditarily, nature-wise, then nurture-wise, environmentally, because that person acts the way they do, that is also conditioned into you. So it's a double barrel, double situation. And then there's neurobiological factors, neurotransmitters don't work well for serotonin and GABA. You seem to have a higher levels of norepinephrine for the anxiety disorders. There's personality factors involved, behavioral inhibition. Now we've all seen children and they all go through this little age, just kind of before 2 years old or so, where they become intensely shy. They may have they may go the first year and climb into anybody's arms and hold them out, but once they can walk and get around, all of a sudden they're grabbing a hold of mom's leg or dad's leg, and whenever anybody comes around. Now, that's normal, or let's say it's not abnormal. What is abnormal is when they don't get over that, and that they get that social anxiety that carries into adolescence. This also ties in with neuroticism, which is that list of things on the right-hand side. There's also the cognitive or the thinking factors that go along with the risk factors. There's a sustained belief that bad things are going to happen. And there's a whole lot of that going on in the world today. I'm not going to get into the politics, but there's a whole lot of people worried that things are just going to get worse and worse and worse now with the new president. There's people have more and more moved towards an external locus of control. They feel like they're not in control of things. No matter what they do, it doesn't make any difference. This can be exacerbated by overparenting, strict parenting, helicopter parents, not allowing children to make their own decisions or suffer any consequences. So that at some point they lose all sense of self-control and become just pinballs bouncing around in the world. It's also the hypervigilance or a tendency to have an intention to threat all the time. And next week when we talk about PTSD, this is what happens to a lot of people, a lot of soldiers that suffer PTSD. Because they are hypervigilant, they have to be watching all the time. They don't know who they can trust in these war zones. Not everybody's in uniform, so they know the good people from the bad people, and they have to be worried about roadside bombs and IUDs and so forth. So they're constantly vigilant, and after a while, it just exhausts you. And we'll talk about more of those symptoms next week. So how do we treat anxiety disorders? Generally speaking, exposure works for most of them. You face a situation that triggers the anxiety, and you learn to overcome it. And this can be done in systematic desensitization, a little relaxation, imageal exposure, a little bit at a time. They're having great success now with virtual reality. So in the bottom right, you see the person being treated for fear of heights, knowing that she can't really fall off the edge of the building. So these are treatable disorders, and they all have to be tied in with cognitive approaches, cognitive behavioral therapy, positive self-talk, all of those type things. I do want to point out that the image up in the upper right is important to keep in mind, that if somebody has an anxiety disorder or a severe anxiety attack, telling them to calm down is like telling someone with epilepsy, just stop having the seizure. Okay, it only adds to their anxiety. So just file that. There's a lot of medications that can go along with these that are severe. The most popular ones are the benzodiazepines, Valium, Xanax, and then rupees. There's antidepressants when these are tied in with depressive disorders, mood disorders. The problem with all of these is they can be extremely addictive and can have some major side effects. So most of them have to be very closely monitored. So that gives you an introduction into the anxiety disorders. Next week, we'll talk about the obsessive compulsive and trauma-related disorders. They all come under the umbrella of anxiety disorders. So have a good week.